So, welcome to the session on interventions for Parkinson's with Professor Peter Silburn at the end there, Dr. Stephen Tisch in the middle, and Sarah Bray to my right. Welcome and thank you for coming. So this is just going to be a question and answer session, and then we're going to open it up to the audience because I'm sure with a panel of these three experts, you will all have many, many questions for them. But starting with Stephen, explain briefly what MRI-guided focused ultrasound is and what conditions is it suitable for?
So MRGFUS is an incisionless neurosurgical intervention that uses high-energy ultrasound beams to pass through the skull without requiring a skin incision. And the ultrasound beams you can think of almost like an ultrasonic scalpel, and they converge in a focal manner and allow us to ablate or destroy a few cells within a part of the brain called the thalamus, which is an important brain relay. And by disrupting that small area of the thalamus, we can actually interrupt pathways that are propagating tremor. So it is a form of neurosurgery, but its major advantage over traditional forms of neurosurgery is that it's done incisionlessly in a very short procedure that only takes about 2 or 3 hours to do. Its main role at the moment, where the evidence is strongest, is something called essential tremor, which I've been lucky enough to meet an essential tremor patient today. So there are some people...
Shaking hand, put your hand up.
Nicole?
Thanks, Nicole.
Yeah, so there are some people in the room with essential tremor, and obviously there is a sort of complex interrelationship between essential tremor and Parkinson's disease, and it's perhaps not completely separate silos of disease. In fact, there may be some interface between the two that's quite interesting. But what we've found is that we get the best results in people with essential tremor for tremor suppression. And we have been using it in Parkinson's tremor, but the results are a little bit weaker, a little bit less reliable, and not necessarily as sustained. So we still need to do more work for perfecting it for treating Parkinson's tremor.
Thank you. Sarah, you've been part of the team that has been on the trial for VYALEV. For those that don't know, what is VYALEV and how is it different from the duodopa pump?
VYALEV is a continuous levodopa infusion that's delivered via the subcutaneous tissue. Patients wear a pump and it's delivered over 24 hours. It's still under clinical trial. It's not quite added to the PBS yet. It's been recommended by the PBAC, so we hope to see it added to the PBS and available hopefully soon, but we don't know and there's no timelines for that yet. We've been trialling since we started the trials back in October 2019. So it's been more than 5 years now, and we enrolled 17 patients on those trials, and we still have 11 of them on therapy, and some of them are in the room today.
If you're in the room and you are on this trial, if you don't mind, put up your hand. Thank you.
So it's very different to, well, it's similar to duodopa because it's a continuous levodopa infusion, but duodopa is delivered via a permanent tube that goes in through the stomach and delivered into the small bowel, whereas VYALEV is administered into the subcutaneous tissue. So patients will, people living with Parkinson's disease will administer a small cannula or a needle into their abdomen or their thigh, their area of choice, every day, and you rotate that location every day. It's a retractable needle. The needle doesn't stay in your skin. There's just a small plastic cannula stays in.
So if I was the health minister or the treasurer, I would like that because there would be no hospital stay, no surgery, and less risk of infection?
Yes, it's very, it's going to be a popular therapy. It's depending on the model of care and which hospital that you work in. I know that we will be initiating VYALEV on an outpatient basis, but I know different doctors in different centres will do it differently. There is no in-hospital stay where we are, so obviously, that's much cheaper.
So cha-ching.
Yes.
If I was in government.
Yes.
Yeah? Okay,
Yes,
good. Peter, what is DBS and how has it changed or progressed in recent years, and what kind of candidate is suitable?
Well, thank you for the opportunity to talk about DBS. It's the oldest therapy at the moment on our current panel. It's been around since 1980s, and it's certainly not new. But basically what it is that it's a reversible procedure where you place a small 1 millimetre contact, and it's a little cylinder, if you like, and there's a 0.5 mil between the next contact. And in that 1 millimetre contact, you can modulate structures. And when you place the electrode, because it's rounded at the bottom, it doesn't destroy tissue. It kind of parts tissue at the cellular level. And it does a couple of things. It enables us to look at the brain and perform activities in the brain, such as people imagining things, people walking, imagining they're walking. We can therefore study aspects of the brain, but the big thing is we place it in the subthalamic nucleus. Early on, it was a structure in the thalamus that Stephen knows very well about. And when you place it in the subthalamic nucleus, which is not, it's in a sentinel area, it is not destroyed by the Parkinson's process. So when you place it there, you can take away tremor, stiffness, slowness. And in our hands, a third of people come off the medication altogether. 2/3 are on about a starting dose, maybe 1-3 times a day or something. And 10% we just can't crack it. So it's a very important procedure in the armamentarium to treat your symptoms now. And whilst things come along in the molecular and cellular biology world, it will be there if something happens that we found a cure or something that will affect the whole neuronal structure in the brain, we can just turn it off. So it's a very important, very powerful thing with Class 1 evidence published in the best medical journals of the world over many years, and the information is you do it sooner rather than later. Don't wait till you get bad. Yeah.
So you're saying the type of candidates that are suitable might not be what we used to think, which was last case, last resort.
Yeah, correct. I mean, because it's a procedure, everyone worries about it, but it's been done for many years now across a number of centres. Always better to go to centres that are doing it regularly and have a good team, a good whole strategy before you even get to the operation. And the data again, Class 1 evidence published in the best medical journals in the world, you do it sooner rather than later.
Thank you. Stephen, MRI-guided focused ultrasound, and I will keep saying the whole thing so you know what I'm talking about, is on the MBS for ET, essential tremor, but not yet Parkinson's. You briefly touched on it, but what's happening in the world of focused ultrasound and Parkinson's?
Yeah, so I would like to see it reimbursed for Parkinson's as well, although I'd be brutally honest in saying that the evidence base for its efficiency, at least with the thalamic lesioning, is not as strong as essential tremor. So I do have some sympathy for the decision makers in at the moment limiting it to essential tremor, but rather than seeing that as a barrier, I see that as a motivator to continue to try and implement the therapy within a research framework in Parkinson's patients. And I don't think we should close down our efforts to treat Parkinson's tremor and related symptoms using ultrasonic therapies, but we probably do need to convince the decision makers within the federal government that we've got it working as well for Parkinson's symptoms as essential tremor, and I think that will get it over the line. We may not be necessarily restricted to using the thalamic target. And in my talk yesterday, I alluded that our Spanish colleagues in Madrid have published some excellent papers on lesioning the subthalamic nucleus, the same area that Professor Silburn was talking about as the target of choice for deep brain stimulation. Now that presents some additional challenges and complexity, but it's feasible and it's been shown to work. So that's something we're looking to start relatively soon. And in fact, evidence would suggest that it's significantly more efficient for treating not only tremor, but also the other non-tremor symptoms, such as stiffness and slowness. So we might get a far more complete motor therapy with subthalamic nucleus lesioning. So I think that holds great promise as well.
Fantastic. Parkinson's Australia played a leadership role in getting MRI-guided focused ultrasound on the MBS for essential tremor, and we are continuing to lobby for it to be on the MBS for Parkinson's as well, and we'll continue that with the new government. And that's very interesting what you say. Like, we want to present the truth to people in the sense that, you know, it might not be working perfectly now, but I mean, DBS mustn't have worked perfectly right from the start either, did it?
Well, DBS originally, it was sort of serendipity, started off in the thalamus, and over time, way back from the mid-80s and things like that, it did evolve, but what's really changed is the ability to find the target. So in DBS, it's necessary to find this target, but it's not sufficient for a long-term outcome. You need to actually be able to program the condition. And with that, you can now remotely anywhere in the world, you might be on holidays or whatever, we can now adjust all the parameters that would normally require turning up to a clinic. You can be in Paris, France, you can be in Japan, all of these places we've actually programmed people's brains from Australia. And with that, it means that you've opened up a lot of things, reducing the burden of care and cost of care, particularly for people in remote areas in our country. I think that's a big thing. And the technology that's involved in that, you'll be able to apply it for other conditions, other medical conditions. So I think that these therapies will be accelerating, certainly as AI comes in. I mean, Australia's in a good position because we've got silicon-based supercomputers which don't heat up like others with carbon. So this information will come in an autonomous system as well. No, it's going to be big. It's cool now.
Thank you. Sarah, can you tell us about what are the best outcomes and maybe the worst outcomes that you've seen on the trial?
The best outcomes is improving people's quality of life and increasing their good time, so their on time. The adverse events that we see on the trial are skin reactions, but there are ways to manage that. And from the withdrawals that we did have from people in the trial, none of them were related to skin reactions. So changing the cannula daily, being scrupulous with your hand hygiene, making sure that you're not accidentally contaminating your infusion site. There's lots of things that we, as Parkinson's nurses, can work together with you when the drug's available. So I think hallucinations was also one of the adverse events that was reported, but it's also reported in patients without advanced therapies as well. So they were the main ones.
Fantastic. And when we move to question time, if anyone who is actually on the trial would like to speak, then please, I invite you to do so. Peter, in preparation for DBS, someone's been chosen as a suitable candidate, they've done their levodopa challenge, they're going ahead with the procedure, and they have to prepare themselves mentally and physically and emotionally for the actual procedure, but more importantly after, and expectations. How should a person, their carer, their family, manage those expectations for after?
Okay. It's a very important thing, and there's a significantly well-established process in that regard, in that it's like Parkinson's is a whole brain and body issue. It's not just dopamine and it's not just the subthalamic nucleus. As we know, there are many other significant structures. So in conjunction with that, you have to look after the person and their family and their carers. So we have a neurologist, neurosurgeon, neuropsychiatrist, we have general physician and the very important DBS clinical nurses. All of that's been set up before someone comes in, so they've already got their questions answered in that regard. But the big thing for us is that, as we all know, is that you've got to maintain your physical activity all the way through to coming to the operation, say in the hospital, and also keep your brain active. Now, when I say improve and keep yourself physically active, It's core strength, balance, range of joint movement, and regular walking program, for instance, because that, in conjunction with keeping your brain active, there is evidence that neurogenesis changes. Osteoporosis, which is more common in Parkinson's, improved, and it's not all about vitamin D, because vitamin D itself actually has a very important role in neuronal health, if you like, for a broader word. So all of these things are discussed with everybody, and they come in, and the big thing is to sit down the night before as well and just say, how you're going, because it's a very, very important aspect in someone's life, and you want to make sure everyone is on the page. And I can say that even the most anxious people, I don't know about your guy, Stephen, but even the most anxious people, when it comes to that, are on a mission. And they're very good. They just stay on song because they're prepared. But keeping physically active is really important, in general anyway.
But it's true to say that not one therapy or medication is going to fix everything.
Oh.
And this panel is about demonstrating choice, in the sense that if I was a candidate that was completely scared of actually having an operation or, having an operation, then I could actually choose a different therapy. But in terms of what each of you specialise in, expectations has to be managed. And we don't really have anything that fixes everything, do we?
No, not at all. But I think the reversibility of things is important to have. That's a very strong thing, to have reversibility. But remember this, as Roger would know, there's many different types of Parkinson's and symptoms and way people live their lives and react. So if there's 55 languages here in our room at the moment, and I kept speaking English, not everyone will respond. Not everyone will put their hand up. But what we've got to do is then learn a lot from the cellular molecular biology and the subtypes at the individual personalised level, which should hopefully improve as things improve in the digital world, I think.
I think that's a very good point, and I think the mixed results, getting back to the focused ultrasound in Parkinson's tremor, they've been decidedly mixed results. We've had some outstanding results. We've had approximately of our cohort of 19 patients, half have had more than 50% tremor reduction maintained at 12 months or more, and many of them have been now followed up for 2 and 3 years. In fact, moments ago I received an email from one of our Queensland patients who said, I don't want to keep my appointment with you, Dr. Tisch, because I'm perfectly satisfied with the tremor result. And yet we've got 50% of patients who have either had an early or delayed relapse and have not met that criteria of 50% improvement. And that's very frustrating. And we haven't been able to identify predictive factors that would allow us to sort of tell who is going to benefit and who isn't. But there must be some biological reason why some of our patients are responding and some aren't, because it's not to do with the way we're doing the lesion. It may be to do with fundamentals of biological difference of disease, getting back to what Professor Barker was talking about. It could be to do with the weighting within different neuronal networks, that they might have more weighting in one pathway or the other, and we're not covering enough pathways with our treatment. But it's very much what you were saying, Peter, that it's not one size fits all, and all the work and all the intelligence in this room is in actual fact sort of mutually beneficial. So it's very important for me to keep reading the sort of molecular basic sciences and stuff, because you may, although it's not something I'm working on directly, I might learn something that might help in terms of my neurointerventions.
Do you think we'll see combos? So, if I've had DBS and I might have had it for 10 years or so, might I try VYALEV after that?
Yep.
Yeah?
Yes, definitely.
Sarah?
Yes, definitely. We'll see that in the future. Yep.
Before we go to questions, I'd like to invite anyone that's actually been on the trial to actually say whatever they want about it, whether it's good or bad or ugly. But what I might do is give up my microphone to Natasha, and if anyone from the trial actually wants to say something, then you can give them... Oh, Look at you. You're double fisting it. Okay. Is there anyone? Oh, thanks, Paula.
Hi, I'm Paula. I've been on the trial with Sarah and the team at Westmead for 4 years, I think now. I was diagnosed when I was 26. I was first symptomatic when I was 19. Before I went on the trial, I couldn't really walk. I couldn't do anything, really. My life had just taken a standstill as I was frozen. So when I went on VYALEV, it basically... changed my life. Like, it just brought back my ability to walk. I started being able to exercise. It was an incredible transformation for me. It's non-invasive. It's easy to manage. What else can I say? So being a relic here in this room, having Parkinson's for 35 years, for me, it was just a good way for me to continue this, I say journey, but in a positive way, and bring, awareness that we can, actually live with this disease. With Parkinson's. I don't like to call it a disease. I live with Parkinson's with these alternate therapies, be it DBS, VYALEV, or the ultrasound-guided therapy. So, I just wanted to say, it's been all good for me.
Thanks, Paula. Jamie, thank you.
Hi everyone, I'm Jamie. I've been on the trial just a little bit longer than Paula, I think. I was really struggling with oral medications. They weren't giving me the control over the symptoms that I needed. And I was seeing my neurologist. He said, try this, or we're going to have to talk about more invasive treatments, I think. And I've been on it for 6 years. It's not fixed everything, it's not cured everything, but it's made my life so much easier because I forget to take my meds all the time. And if any of you have done that before, which I'm sure you all have, if you're off by 10 minutes, that's an hour for me trying to get back to a regular state. So the VYALEV trial has really, really helped me out.
Thank you, Jamie. After we hear from Mike, I might ask for anyone who's had DBS that wants to just briefly tell us what it's done for them as well. Mike?
Hi, Mike. I've been on the trial since about April 2021, I think, for the VYALEV. I was on just under 2 grams a day of levodopa equivalent of tablets and Bray patch, and I'm up now to just under 5 grams a day. So it's a fairly big dose, but I noticed from straight away it was a double blind, and I had the good stuff. I knew straight away. So and the tablets that they gave me for the placebo, they were huge. So a little bit of really hard to swallow. So sorry.
That's why there's some gloop in your conference packs.
Yeah, that's right. But I found that it's been pretty good for me. I do get fairly anxious. As you can see, I'm shaking like a leaf here. But overall, with the tablets I was taking before, I found my offs, I'd get my shoulder trying to come up like that. And my on periods were down to probably in my cycle 5-hourly, taking tablets during the day. I probably had an hour of good time a day in each 5-hour cycle. So it's been a game changer for me. It meant that I could keep going on with my physio, and it's helped with my it actually improved. We had some improvements with my neuroplasticity from the sort of exercise regime I was doing. So, apart from that, I did have a few skin infections, but it's been, overall, I'd recommend it, yeah.
Thanks, Mike. Can I invite anyone with DBS who would like to speak to the audience? Is that Vicky? Is that what you've got? Thank you.
Hi, my name's Penny Mitchell. I had DBS about 2 years ago, or 2.5 years ago, I think it was, 22. And I was having before. It has been very good. I had severe motor fluctuation beforehand. Like I was having levodopa every 2.5 hours, smaller doses to try and control my motor fluctuation. But I was still getting dyskinesia and severe offs. And so I was probably having about 3 good hours a day before I had the DBS. And so it really was a big game changer for me in terms of my motor, my motor stuff. I want to elaborate on that a little bit, that a concern that I had leading up to the DBS, which is relevant to the VYALEV now. My problem is that now I'm back up to the same amount of meds that I was on before. So I was having a lot of levodopa that was making me sick. And before the DBS, I was having apomorphine while I was on the waiting list for the DBS, which was in COVID time. But the apomorphine has got a similar problem to the VYALEV, I think, because I was one of the people who had those, I had skin reactions to the infusion. And apparently that's a problem with the for about 10% of patients on the VYALEV now too.
Yeah.
And one of the factors that's not considered with that is sulfite sensitivities. They have a preservative in them called sodium metabisulfite, and quite a lot of people are intolerant to this, and I don't know why they continue to have sodium metabisulfite in as a preservative, but it is an issue. It's an issue. DBS seems to be. I'm at that point now where I really need to consider something else that's going to reduce my reliance on the gut as an absorption method for my levodopa treatment. And so.
Thanks, Penny. Hannah, you got someone?
For me, DBS has been the ultimate. I couldn't thank Peter enough and his team. People here, I can see a lot of people, and I've spoken to a lot of people who are concerned about the whole DBS process. You talked about managing the expectation. My experience is the expectation versus the result. I didn't manage it up enough. I wore a track in the hospital carpet. The difference it's made has been unbelievable. I thank you, Peter. I thank your team. And anyone here who wants to know how I went through the process, more than happy to chat. I'm here today, I'm here tomorrow, I'll be here for a long time, so...
Thank you.
As far as I'm concerned, PD can get stuffed.
So this is what we're all about, this panel about, reaching out, speaking to people that, if you've been thinking about something, then, go up and speak to them. It's all about connecting and sharing each other's stories. So, those offers are open. I know you wanted to respond to that, Peter.
Yeah, just to make a comment, if you like, on dopamine. I mean, dopamine has been an amazing thing, and there was a general survey that was done amongst neurologists globally, published in a journal called JNNP. And the question was, what were the top 10 things in the last 100 years of neurology in terms of Parkinson's? And the two things that stood out was the finding of dopamine and its application, and the second one was DBS, amongst people all around the place. And I think the late, great David Marsden, who kind of knew everything, that guy had a brain as big as the planet, his top two things in his time as a complete expert in it was the two things with dopamine and DBS before even all that came out. So
yeah, I heard my mentor, Patricia Limousin, tell me exactly the same thing, that David Marsden said that the two biggest advances in Parkinson's in his lifetime were levodopa and then deep brain stimulation.
And I think the DBS basically is not just all about dopamine, otherwise we wouldn't be able to get people off the medication, correct? So it's doing many other things, and that's because, if you think of the human brain as an ecosystem, that's co-evolved over many years like all ecosystems. And those structures that help each other have been generated over millions of years. So when you actually place an electrode, like we do, place an electrode in a very tiny area, it's actually affecting huge amounts of the brain, different parts that involve many other neurotransmitters and many other structures that are involved in Parkinson's. It's not just about the substantia nigra.
Can I just make a plug for neuroprotection or neurorestorative therapies or disease-modifying therapies, whatever you want to call them, because I'm very interested in those efforts to find drugs or combinations of drugs that might slow the disease down. And I think those types of therapies are going to be totally complementary with things like deep brain stimulation and VYALEV or whatever else we come up with. Because if you think about it, we may be able to press pause on the disease progression, but not necessarily reverse all of the existing damage. So what we really will still need is good symptomatic therapies, and they could be highly complementary with disease-modifying therapies. And then you kind of getting towards a sort of stage that Professor Barker alluded to in his talk, where we had this transformation in HIV disease, where it was a death sentence initially. And now some of the HIV wards at St Vincent's have had to close because we just don't have any patients with it anymore. So, you can have a sort of a neutralising effect on symptoms and disease progression, and it sort of becomes maybe a non-event in the future. That would be the dream.
And not just drugs, exercise, hydration, nutrition. Can we please move to questions? Hannah, do you have someone with a question? Just here. Thank you.
Hi, my name's Jenny, and I've had Parkinson's since 2016, at least that's when I was diagnosed. And I would have loved to have got onto your trial, Sarah, but I couldn't wait till it was on the PBS. So, in fact, I've gone down the duodopa route. I had the peg put in October, and I'm still just getting medication titrated, but it's much, much better than it was without it. When will the subcut levodopa be available to us who have been waiting a very long time?
So, Sarah's not going to be able to answer that question, and nor can I.
I'd love to be able to, but unfortunately I can't.
Yeah, so the position is, and I did say this earlier in my opening speech, is that at the moment, AbbVie and the government are in negotiations about pricing. They will keep us informed of when it'll be available on the PBS, but all those rumours that you're hearing about months and things like that at the moment are just that. They are just rumours. And no one in this room, not even AbbVie representatives, can answer that question, unfortunately. Sorry, Jenny. Over there.
Can I just make a comment on that, though? That continuous levodopa infusion duodopa is available now. It's on the PBS. And so if people cannot wait for VYALEV or don't wish to wait, then that's a treatment that you can access right now.
Hi. Hi, my name's Elizabeth, and in 2009 I made the trip up to Brisbane and got diagnosed by Professor Silburn. I then went back to Brisbane in 2016, and he and his team did DBS on me. Now, DBS for me, it's made my emotional incontinence much worse. So I cry all the time when I get up and speak like this. That's not me, if you knew me before. But in those days, I think I'm right in saying, the emphasis was on its impact on motor symptoms. But for me, it's always been an impact that's on the quality of life. And I remember coming back to Canberra after the DBS and going back to see the counsellor that I'd been seeing for a couple of years. And she said to me, Elizabeth, you've changed completely. She said, for years now, you've just worn black. She said, but now you have colour. You have a touch of red or a touch of colour around you. And I think that's continued to this day. I now am under Dr. Tisch. Dr. Tisch is wonderful in terms of giving me support for continuing with my cognitive work and also support towards my emotional stability. So I'm delighted. In that sense, it has changed my life. It's changed the life I might have had. Thank you.
Thank you.
Thank you.
A question down here with Vicky.
Dr. Tisch, I'm really interested in your therapy. So yesterday you were saying that it obviously treats tremor. That's been the kind of the thing that you've been working with, essential tremor especially. Today you mentioned that it might actually do something similar to DBS and actually go beyond just treating tremor if you move the location slightly. Am I right? So because it's an ablation, it's unreversible. But you mentioned also that the risks of maybe ataxia, I think it was dysarthria, that might see after the procedure disappear within a couple of weeks. So what are the negatives of having that? Because it does sound like an amazing alternative to DBS.
Yeah, so it's generally considered relatively safe from a neurosurgical perspective in that there's been no reported hemorrhages or strokes resulting from the intervention. So that's perhaps a point of difference to penetrative neurosurgery. However, it is an ultrasonic scalpel, and if the lesion is not well placed, you could cause considerable damage to the patient. Luckily, as a tool, it's incredibly accurate. So it really delivers the energy and the focal ablation where we specify with an accuracy of about 0.5 millimetre. So we can very consistently lesion the desired target area and spare the surrounding structures where side effects might be incurred. Now, if you think of the thalamus like a house with different rooms, we're trying to be in the bedroom, and just next to the bedroom there's the bathroom, and then there's the kitchen next to that. You don't want to be in the bathroom, you don't want to be in the kitchen. But if you make a decent sized lesion to cover the whole target, you might just touch up against those adjacent areas, and that's really how we incur side effects in the procedure. Now, usually those side effects are temporary when the lesion is first created because it's bigger at the beginning and then it heals. And that's why we see this characteristic temporary unsteadiness of gait, or sometimes in a small percentage of patients, temporary numbness and pins and needles that goes away, or temporary taste disturbance. But the side effect profile will depend very much on the target. So I've told you there about the side effect profile for thalamic VIM lesioning. I haven't got any personal experience yet with subthalamic nucleus lesioning, but that will bring its own side effect profile because there are different neighbourhood structures. So for example, in the subthalamic nucleus, from speaking to my colleagues in Madrid, they are quite cautious not to induce dyskinesia, which can be a side effect of subthalamic interventions. But overall, with the subthalamic ablation, and there's 2 major published papers that you can look at, one in Lancet Neurology and another one in the New England Journal, very sort of elevated journals, the safety seems acceptable. Not perfect, but as a neurosurgical procedure goes, acceptable. So I think we've got some very encouraging developments for focused ultrasound in Parkinson's, but it's still a work in progress.
Thank you. Up the back with Natasha.
Hello?
It's on.
Oh, cool. My name's Lee. I've had DBS. I got my implant put in 2017. I've been diagnosed since 2009. But it was an absolute game changer for me. Completely changed my life. I'm at the point now where there's some talk of putting extra leads into a different area of the brain to help reduce the side effects or the dyskinesia from the levodopa. I'm wondering if I guess my question is there much, have you heard of this happening in many cases before?
So the question is about a secondary procedure.
Yeah.
Sure. Yes, it's been done quite a number of times, and what I'm hearing, and we'll just talking with Stephen, it's most likely in the globus pallidus internus, which is a target in the brain that's particularly useful for reducing dyskinesias, drug-induced, DBS-induced even. So you can have them in both the subthalamic nucleus and the GPI. You can have them in the thalamus and the GPI. And the other one that we've kind of pioneered for some time was in the pedunculopontine nucleus. And we published our work in that Nature Neuroscience many years ago now. And that helps predominantly on-time freezing and falling. So these structures you can reach, and we can reach them much better today with the technology that we have of seeing the target on the MRI, looking at the neurophysiology, watching the individual brain cells in that area work. And then once we think we've seen them work, then we actually place the permanent electrode in. This has been done basically because it's a reversible procedure and it's not damaging tissue going in and out, okay?
Thank you so much. One more question, please. I'm sorry, we're going to have to break for lunch. So I think with Vicky. Thank you.
Hello, I have a question with regards to DBS. And I'm sure a lot of people in the room could answer this question as well. I'm looking at possibly doing it, and when it comes up to the scary bit in the operation when they wake you up, do you have any recommendations for that?
So you can have your operation awake or asleep, can't you, these days?
You have it awake or asleep. And like I said before, even the most anxious people, when you get into the operation, everyone's got you calm, the anaesthetist has got you calm, and everyone's talking to you, and it just seems to not be a big issue in there. But you can also have it asleep, and you guys might have done more asleep.
Yeah, so we probably, on the whole, do the majority of the procedures with the electrophysiological recordings and the testing awake, and that's certainly a popular and traditional way of doing it. But in selected cases, we can do it under general anaesthesia. And the results, although there are no sort of randomised head-to-head studies, the results seem to be equivalently good with both forms of procedure.
Yeah. On a personal note, in the awake surgery, the thing that got me way back in the late 90s involved was seeing someone looking at their hand. It was rigid and had a kind of odd movement in it when the drug was off, and he was like that for about 12 years or so, and it just sort of popped, and he was in the frame looking at his hand, seeing it move, and I thought, we got to do this stuff, you know? It was amazing, and he went back to his job, and he went very well for some time. But always remember, everybody who's involved in this doing it at a serious level, not 1 or 2 or 5 or 10, everyone who's involved is going to do their best for you. Otherwise, we get rid of them out of the team. Okay, that's just how it goes.
You heard it here first, people.
And you just got to cut it. If they're not into it with you, they're out. And perfect is the enemy of good, but everyone in the teams who are doing it properly in the DBS world will do their best for you. That's just how it is.
Did you want to?
I just wanted to ask Sarah a question. I know we're short of time, but as an expert in all of the infusional therapies, I'd be interested to where you see the infusional therapies going now that VYALEV will probably make a very big impact, and whether you feel that there'll still be a role for duodopa and subcutaneous apomorphine.
There's always a role for duodopa, I think. I think the popular therapies of choice will be DBS and VYALEV, and they will be probably what we'll be doing a lot of at Westmead anyway. And that's, well, with VYALEV in particular, it's the ease of initiation and administration and the outpatient titration. It has a lot of advantages for the patient, of course, primarily, but for for us as nurse specialists and our clinicians, our movement specialists, to be able to initiate in the outpatient setting is really an advantage. For us in a large public hospital, that is an advantage.
Can you please join me in thanking our panel?